Now, for the first half of my career, the first 10 years, in fact, I thought of myself as an orthodontist. I moved teeth. That's what I was trained to do. And then when I pulled back and got a little perspective on it, I realized that I was this guy. I was really good at taking malocclusions, jacked up car crashes of jaws and teeth, and I could get them to straight. I could realign jaws, I could realign teeth, but this was my career. This was the career I was trained to do. It's not what I wanted to do, especially after seeing patients like Maddie. So I kind of went back to my thinking of craniofacial development, and we've heard this from a number of speakers over the last couple of days. If you think about how the jaws grow and how the head and face and oral structures grow, you'll know that the cranium is relatively well formed after birth, but the facial bones and the dentition, the blue part of this, the part where we work as orthodontists, that more than triples, where the cranium doesn't even double. Now, if you think about that, relative to so much of what you've heard over the last couple of days, when is this car crash happening? I was trained, like many of you were trained, to treat in one phase. Wait until the permanent dentition has arrived. How much facial growth has happened? How much of the car crash have we been watching? Now, as I gain more perspective 20 years into my career, I thought I was starting earlier because I did a lot of phase 1 cases. So I'd start at 7, 8, and 9. And I thought I was catching those car crashes. The more I learn about this, the more I'm thinking, I'm still too late to the car crash. We need to be able to identify these very, very early to be effective. And as an orthodontist, I want to be this guy. I want to prevent the car crash, and all the things that I was working so hard on as an orthodontist, impacted canines and poor axial inclinations, all those things were a result of an early car crash that I was trying to fix. Now, we've heard a lot about airway, especially this morning, and I'm going to introduce you to a couple of concepts that have been touched on but not discussed a lot. But as I was introduced to airway, I didn't plan to become an airway orthodontist, and I still don't think I am. I don't think that's what we practice in our practice. I'm an airway-aware orthodontist, but when I first started looking at it, the most surprising thing is what you're seeing on the screen right now is a normal airway. And when I started looking at the cases we were treating at 7, 8, 9, and 10, these are the airways that I was seeing. Was this a coincidence, or was this somehow related? It's the chicken and the egg argument. Is the airway contributing to the malocclusion? Malocclusion contributing to the airway being small? I think these are so intertwined that our scientific minds want to pull them apart and make it simple. Just get the teeth straight and everybody will breathe right. Just make the airway big and OSA will go away. And it's not going to be that simple. This is a bad airway. It's one breath. That's 2. All night, this kid is trying to sleep and recover and grow, and their brain's trying to process things. You can imagine how difficult that must be. If all you do is identify those children and serve as advocates for them and their parents, you will change the lives of a lot of people in your practice. So what do we know so far about this? You've seen a lot of really great research, especially over the last hour and a half, but I'm going to start you with some baby steps, and I'm going to show you just a couple of articles that might open your eyes from an orthodontic perspective. And I want to introduce you first to what's called MCA, or the minimal cross-sectional area, And this was done by a physician named Schendell out of Stanford as well. And it's simply just a documentation study, looking at 1,300 patients of all ages and just measuring one simple thing, the smallest circumferential area of the airway in the pharyngeal space. Here's what Schendell found. The airway does get bigger with age, at least in this sample. And it gets bigger by approximately 10 square millimeters per year of life. So on average, if we're using this Schendell study as kind of, here's 1,300 patients looked at over time, airway gets bigger from 6 to 20, which is a good thing. And this is why a lot of physicians will wait on doing anything that's airway related, because they know the airway's growing, things get better, let's not take tonsils out or adenoids out, everything's gonna resolve, they'll be breathing fine by the age 20. The problem is after 20, everything gets worse, and the airway gets smaller. That tube, that flappability that Dr. Liu was talking about, if that tube is really floppy and it's small, it's harder to keep it open even if you turn up the velocity. So the goal for me is I want to try and get that tube as big as we can get it. Now there's been some correlation studies with how big that tube is relative to OSA. And this is what the correlation studies will tell you. Anything that is less than 50 square millimeters is correlated strongly with OSA, and then all the way up to above 150, there's no correlations. Now, this measurement is not the diagnosis of OSA, nor is it the cause. It's correlated. There's a lot of things we have to look at. Here's an interesting study between snorers, people that are just loud sleepers, a lot of air passing through their airway, and it's audible, but they're breathing well. And it compares those snorers with a group of patients that actually have true obstructive sleep apnea. It's a CT study, so it's not cone beam CT, but medical CT, and here's what they found. They divided the measurement areas into the retropalatal area and the retroglossal area. And what they learned is that the differences between their snoring group and the OSA group is all of the narrowness was in the retropalatal area, where they didn't find any significance in the retroglossal area, which is curious. Here's another study that looked at MCA a slightly different way. And what they found is the width of the MCA had slightly more correlation than the AP. So the airways were smaller in the OSA group, but they were also more narrow width-wise. I love that Dr. Liu and Dr. Yoon both pulled up that coronal view of the airway. We forget about that in orthodontics. We've so rarely looked at coronal views or transverse views. We're so used to looking at the sagittal. And there's a lot to that transverse. So perhaps the wider that airway is, the better. It's not all AP.